Walking on a treadmill is a simple task for Clifta Hunt, but just 6 weeks ago, she couldn't even make her bed without having to stop for rest.
Just doing my household chores, like making the bed up or cooking or doing anything. I can do it a little bit at a time, and I just have to sit down.
These are typical signs of aortic stenosis, which in medical terms it's a very tight valve, and the valve becomes like bone, and it gets calcified, and it looks like bone when you excise it surgically at operation when we have to do an open operation.
Clifta was considered a high-risk patient for typical valve replacement surgery because of her other medical conditions. But a new procedure called TAVR, Transcatheter Aortic Valve Replacement, is designed especially for high-risk patients. It's performed at St. Vincent's and gives Clifta and other high-risk patients an option.
The transcatheter aortic valve is for a patient who's high risk and not right now with the FDA qualifications. It would be a poor surgical candidate, high-risk patient, or even inoperable that is just too high risk. And what patient's risk is over probably 8 to 10% risk of mortality, then we consider the transcatheter procedure.
What the operation does is that we go in and we replace the patient's aortic valve or put a new aortic valve in without having to put the patient on the heart-lung machine.
This is a representation, an animation of the heart with the aorta, and this is looking down on top of the aortic valve, looking actually inside the heart. This is the view that we see at surgery often. The guide wires pass through the femoral artery, goes up through the aorta in the abdomen, and goes up across the arch of the top part here, as you can see, and down. The wire goes through the valve and into the heart. And that's the supporting structure, so we can place catheters over the wire. This is a balloon to enlarge the valve. It's going across the aortic valve now. It's stenotic. We'll pass heart. You notice it's sort of beating very fast right there. The balloon goes up, and we deploy that, and it dilates the valve. The valve with the stent is placed next. As you see, it comes around the arch, has to twist and turn around. It's very big, it's cumbersome. It's probably about 3/4 of an inch or so thick. It's deployed here. We'll rapidly pace the heart again, and it's deployed on the stent. The balloon goes up, balloon goes down, it's withdrawn, and you notice the function of the valve there is starting to work. What this does is relieve all the pressure and the narrowing of the aortic valve. And you can see the leaflets opening and closing with each heartbeat. That's ideally what it's supposed to look like. Seeing this, and then we can show you actually a film from a patient who had one deployed in the operating room. We have just completed a successful transcatheter valve replacement of the aortic valve for an elderly lady who wasn't a poor candidate for operative surgery. As you can witness in the video here, the balloon goes in, we rapidly pace the heart, the balloon's expanded and the valve is on the balloon. It's deployed, we leave it for about 5 seconds, deflate the balloon, and there's a new functioning aortic valve for relief of symptomatic aortic stenosis.
Well, I can hold out to walk longer and do more, and when I lean over, I don't get as sick or dizzy like I did before.
The patients that we've done so far have done extremely well. Day 4, day 5, a lot of these people are home without having their chest even open and have a new valve in place. And these people I saw this morning on rounds were already up walking and could already tell the difference. They even look differently because they're not in heart failure. And they will continue to get better. The heart will continue to improve for about 6 months. So these patients will just get better and better. And in 6 months, most of these patients would have been dead had not this procedure been available.